And welcome to the Dr. Bob Show. Every year, 2.5 million people present to the emergency room with knee pain, knee injury. Very, very common at all ages. If you go skiing, you may twist a knee. If you play football, you may twist a knee. If you're playing tennis, you may step wrong and twist a knee. And every time we twist a knee, it can produce damage, pain, swelling, limitation of motion, all that need to be seen by a medical person to make a proper diagnosis to get that knee problem back in shape. We'll be spending most of this show talking about the knee. My guest is Dr. Andrew Poole, fellowship-trained orthopedic surgeon and deals with knee problems every single day. I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll see where exercise and nutrition and sleeping properly and socialization, laughter in your life makes the knee better for you and for society. A lot of information for you. We'll see how all this fits together. We're talking with Dr. Andrew Poole, fellowship-trained orthopedic surgeon, and we're going to be talking about the knee and the surrounding structures. Andrew, welcome to the Dr. Bob Show.
Thank you so much. Very excited to be here, Bob.
Tell me about the knee, and specifically, let's start with the patella. What is the patella?
Absolutely. The patella, or sometimes we call it the kneecap, is kind of the little bone on the front of your knee that you feel when you kneel down, or when you can kind of move it around sometimes when you extend your knee.
What's its purpose?
So it ultimately connects muscles from your upper leg to your lower leg, and it helps us to extend our leg when we're walking and moving around.
Is it easy to injure?
Unfortunately, it is.
Well, what mechanism do people injure the patella? Because there's lots of muscles that will insert to that keep the knee stable, I guess.
Absolutely. I think the two most common that I see are either direct impacts, where the patella kind of gets pushed into the bones that are behind it, or it gets hit from the side and it can dislocate.
Do you ever break the patella? How thick is it? How big is it?
Yeah, it's a little bit bigger than a kind of a $half. It's actually one of the thickest bones in the body, especially from a cartilage standpoint. But unfortunately, with falls directly, especially onto concrete or a hard surface, patients will routinely break their patella.
Painful?
Absolutely.
You have to immobilize the knees. Will it cause swelling if you don't? Does it tell the person, you got something wrong, you need to get fixed?
Yeah, they generally know, I think early on, as soon as they try to get up, that something is wrong. But exactly, we'll put them in a knee immobilizer and keep them straight. And you'd expect significant swelling over the first 48 to 72 hours.
What attaches to the patella? What muscle groups?
Yeah, absolutely. I think the biggest muscle group we think of is our quadriceps, which is made up of 4 different muscles.
So that's where the big thigh muscles.
Absolutely.
They're the ones that do this.
Exactly, exactly. And those muscles turn into the quadriceps tendon, and that attaches to the top of the patella. And then at the bottom of the patella, we have the patella tendon, and that attaches down to the bone here. And that whole system allows us to straighten our leg.
Does it have anything to do with not letting the leg go to the side too much to injure the knee? Or?
No, we have other ligaments that serve that purpose to protect the knee from kind of buckling left or right.
When somebody comes in and says, I fell on my knee, how do you evaluate if it's the patella or if it's something inside the knee?
Absolutely. I think first off, kind of a history and getting a little more information about how they fell and what position was their knee in when they fell. I think an x-ray from a couple different views is going to give us a lot of information if they may have injured their patella.
Do you get a routine x-ray looking for just some basic fractures, or do you go to a CT scan or do you go to an MRI where you really get the knowledge of what's inside that knee?
I think first and foremost, x-rays are kind of pivotal to an orthopedic exam. So we can get some special additional x-rays that maybe you wouldn't get if you just went to the ER or a walk-in clinic. So I get 4 views with all my patients, and that allows me to look at the patella from a couple different angles.
Can you, when you examine the patient, you take the history, you learn how they fell, you learn where their pain is, you examine the patient, you see how stable the knee is, and you see where, if there's localized tenderness, you get a pretty good idea of what you need, what the problem is.
Absolutely. I think normally by the end of the encounter, we have a pretty good idea what happened and what is injured, whether it's the patella or some of the tendons that connect to it, or if it's something deeper in the knee, like one of the ligaments that has been injured.
So when we're looking at the knee, let's go behind the patella, the inside of the knee. How does it fit? How does it keep people from getting pain all the time? What are the cartilages and the ligaments and the tendons that are there?
Yeah, absolutely. So if you kind of move posterior behind the patella, you have your cartilage, which is actually the thickest cartilage in the body. And then it sits right in what we call the trochlear groove. It's kind of a V-shaped or a U, and it kind of sits almost like in a little bit of a cradle, and it moves up and down, and that keeps the patella in place.
Does the cartilage that's there, is it mainly a cushion?
It is, yeah. It's a shock absorber, and it also serves to be kind of a bearing surface. It allows gentle, smooth motion.
Is there either side that's more important than the other, the medial cartilage, the inside, or the lateral on the outside cartilage?
Yeah, great question. I think they're both equally important. I think most of the time people have pain with the lateral cartilage. That's what seems to cause the most problems for patients.
How do they position themselves to hurt that lateral cartilage?
Yeah, some of it I think is just genetics in the way that our bones are shaped, and some of it can be muscular, so muscle imbalance. And patients really, if they're squatting down or going up and down stairs, they can feel a lot of pain, and they can feel that imbalance and that grinding.
Do they ever, you mentioned grinding, can people feel that grinding, that crepitance?
Yeah, absolutely. So they can, a lot of times again, squatting down, they feel that grinding or that crepitance, or even sometimes just extending their leg from a seated position, they'll feel a grinding or a popping sensation.
So I would think, not knowing, that grinding in the knee would irritate the knee and it would get swollen, painful,
Absolutely.
tender. It's a protective mechanism to say, hey, stay off that and go see the
Something's wrong.
doctor.
Absolutely, yeah, those are all the kind of the common symptoms. And so you may feel some warmth, you may see some kind of redness as a part of the inflammation. You'll have swelling and you'll have pain. And those are probably the 4 main kind of symptoms patients experience.
Can you tell how bad the injury is after you've taken the history, the physical exam, and have the x-rays? Is there a degree of tear in the cartilage?
Absolutely. In orthopedics, we love to classify things or make grading systems. So for every part of the body, there's a system with someone's name on it. And so there's kind of, grade 1 to grade 4 type injuries for how, bad the cartilage is worn down. And that is really where I think MRIs can come into play. It gives us a little more information. It allows us to look closer in the knee to kind of help grade the damage.
When you have the cartilage that's torn and causes crepitance or grinding noises, how do you fix that? Do you do a way of shaving the tears that are there? How do you fix that?
Yeah, great question. Unfortunately, there's not a true kind of fix for those tears. We do different things to decrease the inflammation or the pain. So some of it is things like rest and elevation and ice. Sometimes bracing can help support that as well. And I think anti-inflammatories have a huge role in decreasing the patient's pain. From a surgical standpoint, yeah, it's about trying to smooth, if there's a big defect or a big pothole, about trying to smooth that down and sometimes kind of fill in that defect. Other things you can do is take pressure off of it. So sometimes we can realign the patella so that defect is not experiencing as much pressure. And the patient can also change some of their activities. Things like strengthening your muscles can decrease some of the pressure, and weight loss can help as well. It's interesting, the biomechanical studies of the patella, they say it
biomechanical.
So exactly, the studies where they look at kind of the science and how much stress the patella experiences, when we bend down and squat, some studies show that the patella, just this little bone here, can experience 7 to 10 times our body weight. So a small amount of weight loss can really make a big difference to how much pressure is going across the knee.
So there's a lot that can be done when somebody injures the knee to not have surgery and get better to some extent.
Absolutely.
Later on, we're going to come back and talk more about more extensive injuries and why athletes have to have those repaired, and how does that lead to damage later on with osteoarthritis and needing eventual knee replacement. So we've got a lot of information to pull from your brain. A lot of information for us. Stay tuned. We're talking with Dr. Andrew Poole, and we've been talking about the knee. We've talked about the patella, the kneecap, and how it can be dislocated or crushed, broken, causes pain, and very treatable entity. Then we're talking about cartilage, and the cartilage is sort of a cushion, and it can get damaged and have crepitance, grinding noises. Let's talk about the ligaments on the outside of the knee, the collateral ligaments. How strong are they? How good are they? How easy are they to damage?
Yeah, absolutely. Very, very important ligaments to having a healthy, balanced knee. The two ones we think of are the medial and the lateral, or sometimes we'll abbreviate them MCL and LCL. And these are very thick, dense bands of tissue, very, very strong. But unfortunately, with injuries and falls, they can be injured and cause significant debility for the patient.
You know, and as we're looking at athletics, or activities that can damage the knee, we're getting more and more energetic and able to stress the knee even more. So I would think that it would make more knee injuries because of the activity level gets so much better. So which is damaged more, which is easier to fix, which is harder to fix, of the medial collateral or lateral collateral?
The medial collateral is definitely damaged more and is more likely to require some kind of surgical fixation. Many patients can be treated with bracing and without surgery, but in young patients and athletes, sometimes we have to go in and surgically repair those ligaments.
So if you've got a fibrous strand that's really strong, and do you stretch it? Do you tear it? Do you what happens with injury?
Exactly, all the above. It starts out kind of small and you can kind of stretch it, and the ligaments can stretch just a little bit, but they have their breaking point, and once they hit that point, they generally kind of tear, and patients will classically say, I felt or I heard a pop, and you know then when you hear that, something's probably happened.
So when you go in and fix this fibrous strand, you tie it back together, support it, put a new one in, what do you do?
It's a little bit of both. It kind of depends where it was injured and just the setting. So sometimes we can do a direct repair or a primary repair where we kind of sew it back together or reattach it to the bone. Other times we just completely reconstruct it or replace it with a different ligament or tissue from the patient or even from a cadaver sometimes.
Is rehabilitation of a ligament, the medial collateral, the MCL, is the rehabilitation long time, short time, 6 months, 6 weeks, 6 years?
Not quite 6 years, thankfully. But ligaments probably take the longest part of our body to heal. They're very slow to heal. And so it's easily going to be 3 or 4 months before it really builds back strength. So patients are going to have braces and be restricted in their activity. So
we've got the collateral ligaments on the outside of the knee. I guess it keeps it from doing this too much.
Exactly.
On the inside of the knee, we hear doctors talking about anterior cruciate ligament and posterior cruciate. Tell me what those are, how easily they're damaged, and what do you do to repair them?
Yeah, absolutely. So those two ligaments are in the inside of the knee, and they prevent the knee from moving forward or back. And so the name of the ligament kind of tells you what it prevents happening. And so that's really common in athletes and also in car crashes. Again, really strong, tense ligaments that should, with minor trauma, last us our whole lives, but with high energy falls or accidents, these can definitely be torn. And most of the time, those have to be reconstructed. We don't generally repair those, but sometimes patients can do fine without them in select circumstances.
What are some alternatives on repairing that anterior cruciate, the ACL?
Absolutely. I think bracing initially, and I think strengthening of the quadriceps and the hamstring muscles, they also provide support to the knee, and they can help reinforce the patient's knee and give them stability.
One thing that's always shocked me is when somebody hurts their knee and they have to have it immobilized, how fast the muscle begins to deteriorate.
Absolutely.
And become, so you need that exercise to get those muscles back in shape to help the knee. What is the most important type of exercise or activity? Is it just getting a cane and walking, or is it getting against weights, or can you do too much?
Yeah, you can definitely do too much. I think initially we want the knee to calm down, and we need to get the motion back. Motion is so important. I don't want to, not give that its due diligence. And then, it's can you push off? Can you push up from a stair? Can you stand up from a seated position? Those are the activities and the exercises we want to be able to restore to a patient.
When I watch a football game and I see somebody that's hurt their knee, and I see the trainers come out and wiggle the knee and push the knee and do this. Is there a purpose in that, or should they just immobilize that and get that person to the proper x-ray machine?
I think there's definitely a person. There's a purpose to it, excuse me. I don't think on the football field they're going to change much, but you can tell a lot with a good physical exam. Fortunately, in most people, we have another knee that you can easily compare to, so you can kind of pull on the good knee and then compare that to the injured knee, and that can give you a lot of information. But most of the time, that patient's going to get x-rays and probably going to get an MRI to get more information. Yeah,
and it's just something that I've always wondered, because they're trying to make a diagnosis by pushing and pulling a knee that they're suspecting that had been injured, and so why don't you just leave it alone? Don't touch me.
Exactly. Most patients, they don't want to be touched. Now, for the first few minutes after an injury, there's not a lot of swelling, so you can have a small window of getting a good exam, but a few hours later, patients don't want to be touched.
Why is there swelling? What does the swelling do, and how does it help or hurt the body, the knee?
Yeah, some of the swelling comes from the cartilage, and it's a protective mechanism. It tells you that something's wrong, and it tries to lubricate and protect the tissue. And sometimes it occurs from bleeding if you tear a big ligament or you have a fracture.
Do you ever have to drain the fluid out? Do you ever inject into the knee medicines, steroids, some other medicines to help recovery time?
Absolutely.
What do you have as your armamentarium for that knee? There's a swelling. You reduce it, you pull some of it out. Then what do you have to help the person?
Yeah, so generally we do some type of cortisone injections, and there's numerous medicines that can be given, but that cortisone is the best anti-inflammatory there is, so it will calm down the body from producing all that excessive fluid. And that will help patients. And sometimes with arthritis or small injuries, we'll also do a newer injection called hyaluronic acid. Sometimes I just call that gel because it's a special lubricant that's made.
I call it WD-40.
There you go. That works well too. And it makes it simple for patients to understand, but it's a natural compound that our body makes when we're young and healthy. And as we degenerate or we have injury, it doesn't get produced. And so we can put that back in the knee to try to calm down the pain, the swelling, and increase the patient's function.
When can you tell the patient, hey, it's about time you think about giving up this one sport that's been your love of your life?
Yeah.
How difficult is that if somebody has a significant knee injury that's going to not do well with a vicious activity.
Yeah.
How do you present that to a patient?
It can be really tough because certain activities are just very important and integral to a patient's life and kind of who they are. I think runners are probably some of the hardest ones to interact with because they just love it. But you try to look at the grand picture and pick out numerous activities that a patient enjoys doing, whether it's running and cycling and hiking, and say, well, maybe we can't run, or maybe you can't do CrossFit, but here's all these other activities that you can do with friends, or you can adjust how you play tennis or pickleball to allow that patient to be active and do the activities they enjoy.
Yeah, because that makes their life better, and that's
Absolutely.
what the orthopedic surgeon does. Eventually, do people get enough damage or irritation to a knee that it needs to be replaced?
They do.
And
They do.
that's what we're going to be talking about when we come back. How do you determine when a joint, knee specifically in this show, needs to be replaced? And how do we do that? And how good is it? And how long is it going to last? A lot more information. We're talking with Dr. Andrew Poole, and we're talking about the knee, and we've talked about the damaged knee and how we repair it. We've repaired the whole thing pretty good. And now we're going to see, as time goes on, if the injuries at an early age still cause the knee not to do well, and we need to think about later replacement of the knee joint. Do we replace the knee joint?
We sure do.
Is it something that gives the patient a lot of relief?
It really does. It's a fantastic procedure.
Tell me about the difference from a half knee replacement and a whole knee replacement.
Exactly. So there's three parts of the knee. There's the medial, the lateral, and the patellofemoral. And if one area is really diseased or painful, we can focus just on that area and we can replace just that. If the global knee is worn out and degenerative, then most of the time we'll recommend to go ahead and do a total knee replacement.
Can you tell that by looking with an MRI how shot the knee looks? And,
Absolutely.
And if there's just half of it, we can design to have 15 years of comfort by not having to really go inside the whole knee. So different companies make the different knee replacements.
They do.
What type metal do they normally use?
Most of them are either titanium or a cobalt chrome alloy.
And they're made to where they glide and they don't cause anybody any trouble of any kind. And we see people with knee replacements all the time that do so well. As a matter of fact, I've got replacements in both knees at two different times. So I'm becoming an artificial joint man. Let's talk about how you do a knee replacement, the total knee. How's it done?
Absolutely. So when I do a total knee, the goal is to ultimately remove all of the painful generators for a patient. That's bone spurs, those osteophytes, meniscus tears, ligament injuries, and just that damaged cartilage and sometimes even little fractures in the bone.
So you go in there on one knee and you're looking for all that and you're fixing all that at the same time.
That's the goal. That's the goal, is to do these things and do them well to get the patient back to doing the activities they enjoy and to give them a pain-free life.
Show me a knee replacement right here.
Yeah, absolutely. So this is one of our knee replacements we have. This is the total knee replacement like we talked about. And so in here, you'll see where we replace both the medial and the lateral part of the knee, and we also replace the front of it.
Does that glide easily? And you sew it back together?
You normally you glue it almost with like a cement, generally will hold the knee in together. And sometimes you can actually we call a press fit. You put it on there so tight that it holds itself in place and the body grows to it.
That must be exciting to watch a patient with a crummy knee, a bad knee, a damaged knee, and to be able to replace that where they say, gosh, I I don't have any pain in that knee anymore. Are you that good where we can make the...
We are. I think we are. That's why I got
too.
into this job. I remember having that patient when I was in high school working with the doctor and the difference that it made. And that's ultimately what drove me to do this. And today you talk to patients and see the improvements or see how they've maintained independence. And it's just really exciting. I really enjoy my job.
That must be a thrill.
Absolutely.
When you take a bad knee and make it into a good knee. Andrew Poole, you're a great teacher. Thank you for coming to the Dr. Bob Show. I always remind people there's 4 things we need to do to keep our body and our knees healthy. Number 1 is exercise. That strengthens the muscles, that keeps that knee in shape. We've got to get 7.5 to 8 hours of sleep to stay rested so we can make good decisions on what kind of activity to run and how much trouble we're going to have if we don't treat our joints properly. We are what we eat, and so we have to know that nutrition is a very important part of how our body reacts to the stresses that we put on it. And then I say in the Dr. Bob Show, the thing that we like the very most is the laughter in your life. And you and I have certainly had a good time enjoying listening about and learning about the knee and how you can take a damaged knee and make it into a knee that's functional. You can do what you want. So that laughter in your life, we say, find that person you love and tell them funny stories and laugh a lot. And the more you laugh, the healthier you'll be.
I agree.